My name is Dr. Jason Rogers. I'm a professor of cardiovascular medicine and an interventional cardiologist at UC Davis Medical Center in Sacramento, California. The title of my presentation today is Transseptal Chordal Replacement Early Experience. This is a very exciting area of device innovation and development that ultimately should allow one to place chords on the mitral valve to treat prolapse with a minimally invasive, really transseptal and transvenous approach through the femoral vein. These are my disclosures relevant to this presentation. As a matter of background, we of course recognize that primary mitral regurgitation is by definition a leaflet problem and generally does not involve derangements of the left ventricle. In the Carpentier classification, type 2 denotes leaflet prolapse or flail, which is shown here in a variety of manifestations, including chordal rupture, which can occur in isolation or in a group, myxomatous leaflets with prolapse, and varying degrees of flail. Now, when a surgeon approaches the repair for primary MR, there are numerous tools that can be used. Annular rings are used in almost every repair, either for stabilization of the annulus or actually annular reduction. But the heart of surgical intervention is leaflet repair. And we know about the sort of respect or resect schools of thought related to this. We see in the center an image of leaflet resection or plication. And on the right, we have PTFE chordal implantation, which is really a kind of respecting or repairing technique used. Finally, for valves that cannot be repaired, there's either mechanical or bioprosthetic valve replacement. But the focus of our presentation today is really the transcatheter placement of chords. So this harvest from the STS adult cardiac surgery database of 87,000 patients over about a 6-year period that underwent isolated primary mitral valve operations shows us that about 60% of these patients had repair and the remaining had replacements. And I think it's very interesting to note the mitral valve repair techniques that were used. You can see that annuloplasty was used in 94.3% of patients. Leaflet resection techniques were used in 46.5%. But in a solid third place are artificial chords at 22.7%. And the average number of chords implanted per patient in this registry was 2.0. When we think about transseptal chordal replacement, there are some pros and cons to this approach. Now, the pros would be that with our experience in other transseptal mitral repair devices such as MitraClip, we've become quite familiar with the transseptal approach, and we can avoid transapical access, which quite frankly is really just a form of surgery. We can also mimic the native chordal length using transseptal chordal replacement. As you'll see, we preserve the mitral anatomy and geometry, and I think most importantly, the adjustments to chordal length and tensioning can be performed real-time under TEE or echo on a beating heart. So there's little guessing involved, and one can really titrate the tension level to the desired result. Advantages also include no mitral stenosis and preserving future options. Now, in the con category, there are technical and imaging challenges that are still being evaluated, and we'll talk about some of those. And the durability of anchor and chords is unproven, although most of the technologies use PTFE chords, which are used surgically, so we know something about that. And of course, there will always be unique short and long-term complications to these approaches. So although this is not the focus of this presentation, I wanted to at least mention that there are transapical chordal replacement technologies, and the one that has the most experience, well over 1,000 patients treated globally now, is the NeoChord device. And this is a transapical entry point, and there's a system that allows a cord to be placed on the free edge of the prolapsing leaflet, and then each cord can be anchored individually to the apex as shown in the video. Now if you want to put second or third cord in, you'd put sequential transapical delivery system in, and then each of those would be tied down separately to the apex. Now one thing to notice about these transapical approaches is that the chordal length is much longer than the native chord. You can see that in this animation, the NeoChord here is yellow, whereas the native chord is white. And so I think there's some unique forces on a longer chord, and certainly the vector and where you get transapical axis is very important for the correct chordal alignment. So depending upon the segment that you're anchoring, you may want to adjust your apical axis site. The most success with these technologies have really been in the P2 isolated prolapse population. The efficacy seems to be somewhat less as we get into the P1 and P3 segments. Another transapical device shown here is the Harpoon device. This is similar. It's a transapically delivered device. The anchoring here is a little bit different. Instead of being at the free edge of the leaflet, you can see that really this is targeting more the body of the leaflet. And there's a unique kind of bungee anchoring loop that's deployed on the atrial side of the leaflet that allows one to anchor the cord to the leaflet, and then this is also secured to the apex of the heart like the NeoChord device. So similar idea, but a little bit different in where on the leaflet the chords are being targeted. Now moving on to transseptal chordal replacement. To date, there's only one device that has been performed in humans, and that's the pipeline transseptal chordal replacement. There's a series of panels here that show you the basic steps of this procedure. Pipeline is a wholly owned subsidiary of Gore. In panel A, we see placement of a neopapillary muscle anchor. So this is a kind of neopapillary tower that serves as the anchor, but it brings the chordal attachment point to the same level as the tips of the native papillary muscles, and this is very important. Panel B shows the next step, which is placement of a pledgeted Gore-Tex cord to the free edge of the prolapsing segment. Panel C shows the delivery of a locking device that attaches and secures both the anchor cord and the leaflet cord together. And one can deliver up to 3 mitral leaflet cords per ventricular anchor in this system. And then after tensioning under real time, the device is cut, and the final appearance here is shown in panel E. So this is done through a transfemoral transseptal approach. It's a 24 French guiding catheter, which is the same as MitraClip. The system uses proprietary Gore-Tex cords and leaflet pledgets. It's adjusted under TE, and as with all these devices, since there's no leaflet restriction, there should be no mitral stenosis, and it should fully preserve future options. Here's an animation of the pipeline procedure. You can see the prolapsing leaflet, guiding catheters placed transseptal, and this is the neopapillary anchor being placed. And you can see the top of this is really matching the same height of the native leaflets. Now we have a pledgeted cord placed onto the mitral leaflet, and in this case there are 2 separate cords. And then these are all gathered together into what's called a suture lock. and the suture lock is advanced down into the neopapillary anchor. And then here's where the tensioning step is performed under echo. Each pledget can be individually tensioned and then locked and then cut. And this is the final low profile appearance of the device after anchoring. So a lot of preclinical work's been done on this, numerous animal studies. This is some gross pathology of chordal implant that's done under conventional surgery versus chordal implant that's done with the pipeline technique, and the healing has been very similar. And you can see that the length of the chords is very similar to the native chordal length. These are not longer than the native chords. So we recently reported the first-in-man patient with the pipeline device, and that was published in JACC Interventions this year. This was a 56-year-old man who was symptomatic, had isolated P2 flail with 4+ MR, normal LV function. And I should point out that the STS risk score on this patient was very low. And that will be the target of this device initially, will be patients that are in fact candidates for open conventional surgery. A lot of these patients with isolated P2 flail will be younger. They will frankly be good candidates for conventional surgery as well, but the ability to do this even without a sternotomy is still appealing. These are some baseline transesophageal echocardiographic views. This is the baseline 4-chamber view showing you some of the prolapsing posterior leaflet. You can see the anteriorly directed jet of eccentric primary mitral regurgitation in this image. And this is a left ventricular outflow tract view, and you can really see the torn cord and the flail P2 segment with a large PISA and a anteriorly directed jet. We really value the three-dimensional TE view a lot to define the extent of anatomy and really give a nice, almost surgeon's view of the valve. And we see here a very wide P2 flail in this patient. Now in this particular patient, there was a CT screening step. We looked at the angles and the relationships of the valve to the papillary muscles and to the apex in terms of our procedure planning. And this is something that's being evaluated with all of these technologies. How do we deliver these devices safely and effectively? And in this particular patient, we did make some measurements of left ventricular wall thickness to ensure that the ventricular anchor would be adequately seated. So in this particular patient, we were able to successfully deliver the ventricular anchor and 2 pledgeted cords to the prolapse segment. And this is before tensioning. This is what we call an X-plane view. So on the left, we have a bicommercial view, medial and lateral, and on the right, we have a LVOT view with posterior and anterior view. So this is before tensioning. You can see the prolapse segment is still significant. As we start to increase tension, you can see and appreciate how the prolapse segment is starting to be reduced. And you can see actually the bright chordal pledget pulling down on the leaflet. And on the right, the prolapse is becoming less prominent. Under final tensioning, you can see that the prolapse is essentially eliminated. And in the LVOT view here, there's now excellent zone of coaptation that's achieved between the anterior and posterior leaflet. So this is with color, and there's really no significant mitral regurgitation residual. The zone of coaptation previously was 0, is now 8 millimeters, and there's no mitral stenosis with a mean diastolic rating of 1 millimeter of mercury. This is the postoperative day 1 transthoracic echocardiogram, and on the right you can clearly see the anchor embedded in the ventricular wall at the top of the neopapillary muscle, and then the NeoChordal length attached to the posterior leaflet. So this patient did very well initially. In full disclosure, there was some anchor migration in this patient, and he eventually had to go on and have conventional surgery, but he did well and is alive to this day. But I think this case is very important because it shows proof of concept for transseptal transfemoral chordal replacement, and a lot of these technical issues will be worked out, and that's part of why we do these implants, is to learn how to improve the device and make it fail-safe in the future. Now I'll briefly go through other technologies in preclinical development. None of these have yet been used in humans to my knowledge. The first is the CardioMech device. This is a transcatheter transseptal mitral valve repair system in preclinical development. In panel A, you can see the first step is to anchor a cord to the leaflet. In panel B, this cord is then attached to a ventricular anchor, which is placed into the ventricular myocardium. C is a tensioning step, and D is the device after positioning and being cut. The website that describes this device describes it as a one cord, one anchor solution. So conceivably, if you wanted to do a second cord, you would then put a second cord on the leaflet and a second ventricular anchor. But the basic steps of the procedure are shown in this diagram. The next device that has come to attention is the ChordArt device. This is a transcatheter mitral repair system, and it consists of two nitinol anchors, one on the mitral leaflet and one in the head of the papillary muscle, with the cord in between both of them. Now, transfemoral transseptal delivery of this has not yet been reported, but the device is undergoing evaluation using conventional open surgical exposure. Next is the ChordArt device, and this is a device in preclinical development. And what we see here is there's a looped cord which is anchored to the apex by means of a large pledget. And then the free end of the cord can then be attached to the mitral leaflet and tensioned and then finally cut. So a recent publication described in our paper, or reference in our paper, describes the use of a scaled up prototype, and this is tested on ex vivo bovine hearts, but not yet in humans. I think one of the most unique devices that I've seen is the Mitral Butterfly. This is a chordal mesh repair system. It has a couple components. First of all, there's an atrial wing that stabilizes the implant in the left atrium. There's a swing arm that captures the polymer mesh in a central location. And then the butterfly is kind of this polymer chordal mesh that covers the prolapsing segment of the mitral leaflet. Finally, there's a clasp which fixes the implant to the base of the prolapsing leaflet. So this has been done on a live porcine model, and delivery is currently under direct vision to the posterior leaflet of the mitral valve. There's not yet been any human implants reported. Finally, the V-Chordal system is an adjustable artificial chordal system that allows on-pump chordal implantation with off-pump beating heart length adjustment. So as reported, this procedure is accomplished via a left transatrial approach, and crossing the mitral valve is performed, and a helical anchor is placed at the head of the intended papillary muscle. Once the helical anchor is placed, then a PTFE chordal loop, which is pre-attached to this anchor, is then sutured to the mitral leaflet, and then weaning from cardiopulmonary bypass, final chordal length adjustment can be performed on a beating heart under TE guidance. In our paper, we've referenced preclinical feasibility that has been reported in an ovine model, but there have been not any further reports of a transfemoral system under development. So in conclusion, transcatheter transseptal chordal replacement will be an important tool for the correction of primary mitral regurgitation, and may even allow the earlier treatment of patients with prolapse or flail given that it is minimally invasive and hopefully would have minimal risk. The ability to place cords and tension them under real-time echo guidance on a beating heart is a distinct advantage to open placement, where there may be a lot of guessing involved or surgeon judgment as to the chordal length. In this case, on a beating heart, the length can be adjusted real time and there's no guessing involved. Finally, further clinical studies will be needed to validate these new technologies. Here's my contact information. Please do not hesitate to contact me if there are any questions, and I thank you for your attention.